All right, today we're diving into a really intense topic, urological trauma. We're talking about major injuries to your kidneys, your bladder, and the rest of the urinary system. Now, these organs are incredibly well protected inside your body, so to actually hurt them, well, it takes a massive amount of force. So the question is, how does that even happen?
Think about your kidneys for a second. They're tucked way back, shielded by your lower ribs, and wrapped in layers of muscle and fat. I mean, they're basically bodyguards for your internal systems. So what kind of unstoppable force could possibly get through all of that protection?
Well, in 90% of cases here in the US, the answer is blunt force trauma. We're talking about the crazy, sudden impact from things like high-speed car accidents, a bad fall from a height, or a really hard hit in a contact sport. It's not about something piercing the skin, it's about the sheer, overwhelming force of the collision itself.
Okay, so to really get what happens next, we have to look at the anatomy of the injury itself. How does that raw force actually translate into serious damage deep inside the body?
So right off the bat, doctors put these injuries into two big buckets: blunt trauma and penetrating trauma. And this first distinction is absolutely crucial because it immediately helps them predict what might need to happen next. Get this, over 95% of blunt injuries can actually be managed without surgery, but up to 75% of gunshot wounds, they're almost certainly heading to the operating room.
Let's break down one of the most common and dangerous mechanisms, a rapid deceleration injury, like in a car crash. Imagine this in slow motion. The car hits something and stops instantly. Your body, strapped in, also stops. But your internal organs, they don't get the memo. They keep moving forward because of inertia. That momentum can be enough to literally tear the renal pedicle. That's the vital bundle of arteries and veins that keeps the kidney alive.
Now, let's switch gears. Picture this. A patient from a major accident has just been rushed into the emergency room. The clock is ticking, and the trauma team has to figure out the extent of the damage, and they have to do it fast.
The ER team just springs into action. They're running down a mental checklist, checking vitals like pulse and blood pressure, looking for telltale signs like bruising on the flank, and drawing blood. But one of the very first, most important tests is a urinalysis to look for hematuria, which is just the medical term for blood in the urine. They're also paying super close attention to the patient's lowest blood pressure reading since the accident happened.
Now, this brings up a really common assumption. You'd think that more blood in the urine must mean a more severe kidney injury, right? It just makes sense. But is that actually true?
Well, surprisingly, the answer is no. It's a total myth. The amount of blood is not a reliable indicator of how bad the injury is. In fact, some of the absolute worst injuries, like that renal pedicle tear we just talked about, might show very little or even no blood in the urine. Why? Because the kidney has been completely disconnected from the plumbing, so the blood has no way to get to the bladder.
So if you can't trust the amount of blood in the urine as a clue, how in the world did doctors get an accurate picture of what's happening deep inside the body?
This is where the contrast-enhanced CT scan comes in. This machine is the modern gold standard, and for good reason. A special dye is injected into the patient's bloodstream, and it basically makes all the blood vessels and the urinary system light up on the scan. It gives doctors this incredibly detailed 3D map of the damage, showing any tears, active bleeding, or urine leaks.
But what if the patient is too unstable to even make it to the CT scanner? If they're being rushed straight into surgery, the team can perform something called an on-table IVU. It's basically a quick, single-shot X-ray done right there in the operating room. It's not nearly as detailed, but it answers one absolutely critical question. Is there a healthy, working kidney on the other side? Okay, so the scans are back, the team has a clear diagnosis. Now they face the ultimate decision, the big question: to cut or not to cut?
One of the biggest clues for this decision goes all the way back to how the person got hurt in the first place. And just look at the difference here. Only about 5% of those blunt trauma cases we talked about end up needing surgery, but that number jumps to 50% for stab wounds and a whopping 75% for gunshot wounds. It's a huge difference.
But honestly, regardless of the cause, there are some non-negotiable red flags. If the patient is hemodynamically unstable, meaning they're in shock and not responding to fluids, or if their blood count is steadily dropping, that's a sign of uncontrolled bleeding. Or if a hematoma, which is a collection of blood around the kidney, is visibly expanding, well, surgery isn't a choice anymore. It's an immediate necessity.
Now, remember that immense force we mentioned at the start? It rarely damages just one single thing. You have to think about the ripple effect, especially when the powerful bones of the pelvis are involved.
A pelvic fracture is a sign of massive trauma. The kind of force it takes to shatter those bones is incredible. And you can bet that force didn't just magically stop at the bone. It slammed into the soft organs nestled inside the pelvis, like the bladder and urethra.
When the bladder ruptures, it usually happens in one of a few ways. About 60% of the time, the tear is extraperitoneal, meaning it's contained outside the main abdominal cavity. About 30% are intraperitoneal, which is more serious because urine leaks right into the abdomen. And then in about 10% of cases, it's a mix of both.
And here's another great example of a classic textbook sign that just doesn't hold up in the chaos of a real trauma bay. For decades, students were taught to check for a high-riding prostate as a sign of urethral injury. But in reality, with all the swelling and internal bleeding, it's an incredibly difficult and unreliable sign to assess.
So, let's say our patient has been stabilized. The immediate crisis is over. What does the road to recovery look like, and what are the potential risks down the line?
This table gives us a pretty good roadmap. In the short term, right after the injury, doctors are watching for things like delayed bleeding, or a urinoma, which is just a pocket of leaked urine that collects inside the body. But long term, the main concerns are a potential decrease in kidney function or the development of high blood pressure. The good news, though, is that post-traumatic hypertension is actually really rare, showing up in less than 1% of patients. Which really leaves us with one final, incredible thought. We've seen the violent forces, the high-tech diagnostics, and the life-or-death decisions. But maybe the most amazing part of this whole story is the long, quiet process of healing that happens over weeks and months, deep inside the body. How does the body even begin to repair that kind of profound damage from an injury you can't even see?